This
attending today's
conference will now
webinar.
be recorded.
A very good morning, good afternoon, or good evening to one and all present here virtually with me today. Let me introduce myself. I am Shirley Rose, Conference Secretariat at Coalesce Research Group LLC, and I'll be available for any of your queries or questions throughout the webinar to help you out technically and organize the webinar successfully. For the next 5 minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also the further instructions. Coalesce Research Group LLC is very delighted to welcome you all the speakers, supporting associations, students, and delegates present virtually with us today. With the aim mark the scientific excellence by facilitating conversation, sharing knowledge, Coalesce Research Group follows through the objective of setting standards and delivering excellence in the research among the researchers, academicians, and industries. Before we start with the sessions, I guess some of you will be new to the GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app or the web page, you can find four icons at the bottom center: mic, camera, screen, end. So mic button, click on that to mute and unmute. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera, you can use this button to share or unshare the web camera. If you have the option to share the web camera, you can do it, and it is completely your choice. Screen, you can use this button to share your screen. This is the main part during your presentation. After I call your name, from my side, I will be making you the presenter, and only then only you'll be able to share your screen. So once I make you the presenter, you can click on the screen button and you will find a pop-up window to share your screen. And this is your fourth icon where you can use this to leave the session. On the top center, you can use the options to change your display settings. At the top right corner, you will have three icons: people, chat, and settings. In the chat option, you can chat with me or any other participants. So without the further delay, let us move into the sessions. So the first talk is by Dr. Sarayu Dande from Singha Dental College and Hospital, India. Hello, Dr. Sarayu. Are you ready with your presentation?
Hello. Hello. Yes, I'm ready with
Yes.
the presentation.
Okay, so actually, there's a lot of disturbance. I think you have connected through two devices.
Yeah, because this audio is not working.
Can you share the presentation through your phone itself?
It's not happening that way. That's why I tried.
Actually, there is a resound. Okay, kindly mute your system. Kindly mute the audio in your computer or system, and then you can explain it through your mobile phone. Is that fine?
Okay.
Okay,
Oh,
yeah.
but can I share my PPT through the laptop?
Sure, sure, you can do it. I'll give access to your
Okay.
laptop only.
Okay, please give.
I'm sorry, there is a lot of disturbance.
I think it was better on laptop.
Yes, yes, yes. Yes, please mute your mobile phone.
I did.
Okay. Is it not possible to connect through the laptop itself?
Okay.
Okay.
So, you want
Yeah,
me
leave the session in your
leave?
mobile.
Yeah,
Leave the
no.
session
If
through
you
the
could just
mobile
put
phone.
the session below, I could just start sharing the screen.
Okay.
Yeah,
Yeah,
just
I
make
made you
me
the
the presenter.
presenter in the laptop.
Entire screen share. Yeah. Is my PPT visible now?
Yes, yes, your PPT is visible.
Okay, shall I start then?
Yeah, please leave the session in your mobile phone.
Yeah, just a minute. Yeah, I'm out now.
Yeah, please make it a full screen and start your presentation.
Don't know why it's not happening. Yeah,
Okay, okay, continue with
yeah,
your presentation. Yeah, it's
yeah,
perfect. It's
yeah.
perfect now.
So, good evening, everyone. Greetings from Siagat Dental College and Hospital. It's in Pune, located in Maharashtra, in India. So, I'm currently there as an assistant professor, and I would like to speak up on the topic emerging trends in periodontal therapy. Now, you must be thinking, what is perio? So, perio means gums. You have teeth and you have something pink colored gums surrounding them. So, we need to just look into the pink tissue more. Also, along with the teeth, what we do is just focus on the teeth and leave the pink tissue aside. But then both are equally important for better oral health. So, just let's just go through what are emerging technologies in periodontal therapy. So we'll be going through under the following headings. And starting with my introduction, as I said that yes, the pink tissue around the tooth is very important, and thus the prevention, diagnosis, and treatment of certain periodontal diseases affects the supporting structures. So we need to see if really if there is any problem, the solution to overcome a problem lies in recognizing the problem that exists. If you don't recognize only, you will never come to know. So right from the beginning, if patient is having any issues, just go through n number of periodontal diagnostics, and then we can go ahead with different modes of therapies. So as our knowledge of periodontal disease has evolved with so many years over the period, with the proposal of theories, certain discoveries, evidences, and advances in research, basic sciences and technologies, so have our treatment modalities. And that's the reason we have certain emerging trends. So certain advances in diagnosis, like you have pressure sensitive probes, electronic probing systems. Earlier you used to have only manual probes, but now due to pressure sensitive, you have certain controlled standardized insertion pressure is seen. Then under that we have certain three probes are present: automated probe system, Florida stent probe, and Florida Pasha probe, which detects CEJ, that is cemento enamel junction. Then secondly, we have electronic probing systems which provide constant probing force. First ones were controlled insertion pressure, and second are constant probing force. And they also have computer storage of data. So you don't have to really go on jotting down how much is the probing in the patient, or different modes of the tooth. You have certain different probing levels at the mesial, distal, buccal, lingual, palatal. So due to computer storage, that headache is gone. And precise electronic management, as I said, the constant probing force will help you not to just dot into the deep into the sulcus. With a lighter force, you would be able to detect if there is any periodontal disease. So, example of it would be a Foster Miller probe or a Toronto automated probe, or an interprobe. Interprobe also uses a technology called as fiber optic technology. Certain additional data regarding bleeding, recession, attachment loss, suppuration, furcation, involvement, and also tooth mobility is stored in a small magnetic card, which is later introduced into a printer system. So this tells us that you could also check and jot down in the computer at the side moment, so your headache is gone. Then the next comes is a thermal probe, which thermal, the name itself suggests that it is going to measure temperatures in the periodontal tissues. So, in certain periodontal inflammatory conditions, we know that inflammation itself, one of the cardinal signs of inflammation is temperature, naturally. So, heat is going to be there. So, because of thermal probe, we can actually judge, depending on the temperature, if there is any real inflammation in the tissues or not. And one of the study that was carried out by Hafaje et al. Found that elevated temperature, if found in the gingival tissues, was related to the loss of attachment. And it could be also associated with certain elevated proportions of bacteria like P. intermedia and P. gingivalis, Tannerella forsythia, Aggregatibacter actinomycetum comitans. Certain bacteria which are named, which have certain what do you say, they are seen more in the periodontal disease condition. So it can help us to understand whether the disease is really present or not, whether periodontal inflammation is really present or not. Then the next is ultrasonography. It shows that it is a technique that involves projection of an arrow ultrasonic beam with high frequency to the periodontal pockets. So an example to it would be a perio imager, perio alert, US probe, or a ultra dent. Then certain advances in radiological assessment would be, initially you just had, if you could remember, if you just had the films and then you had to dip it into the developer and fixer and whatnot. But now, over a period of years, we have developed digital radiography, which tells us that this method uses solid state detectors like a charged couple device, CCD sensors, which have a fiber optic technology that is linked directly to the computer. So once you just click a RVG, you just have the image of the radiograph on your computer system. So no headache of a fixer or the different solutions, drying it, or even getting exposed to that more. And in indirect method, you have PSP plates. In direct method, you have CCD sensors. The next comes is the zero radiographs. The zero radiographs are certain radiographic images that are made using an electrostatic process, which may be viewed in a reflected light. Okay. Then the next is subtraction radiography. It involves conversion of serial radiographs into digital images. A serially obtained digital images can then be superimposed and result in composite viewed on a video screen. An example of it, or commercially available, would be computer assisted subtraction radiography or diagnostic subtraction radiography. Then computer assisted densitometric image analysis system, that is CADIA. Here a video camera is there which measures the light that is transmitted through a radiograph. Up till now we saw that the different technologies are either attached to a PC or they have certain superimposed images, but here the camera measures the light transmitted through a radiograph, and then the signals from the camera are converted into grayscale images with help of image processor. And further, the computer then allows mathematical manipulation of the images and storage of them. So this way it is useful. The CADIA system is that way useful for us. Then iodine 125 absorptiometry is nothing but a non-radiographic method that is based on the absorption by bone, a low energy gamma beam that is originated from radioactive isotope I-25. Okay. Then further we have computed tomography that uses special X-ray equipment to obtain image data from different angles around the body, and then uses computer processing for the information to show a cross section of body tissues and organs. This is not used for dental purpose, it is certainly used for medical purpose. And further we have CBCT, that is professionally used for dental implants management or diagnostics, we can say, and mostly used for dental purpose. Then CT scanners certain generates three-dimensional images of dental structures. In this CBCT, we have different scans, and every scan we can study in detail a length and breadth of the either the bone that is available or the pathology that is seen, both can be diagnosed, and it can be easily made us to like for implants, if we are planning to place an implant, CBCT can help us detect the height and width, and thus it can make our life easy. Then further we have MRI, which is mainly for soft tissues. Up till now, the solve was for hard tissues, but MRI is for soft tissues. It is a non-invasive method which uses radioactive frequency waves, and a strong magnetic field is created rather than X-rays. And further, the detailed pictures of internal soft tissues are provided on a scanner or something. Then bone scanning or radionuclide imaging. This is a nuclear scanning test which assesses biochemical alterations. It helps in identifying new areas of bone growth or breakdown. The radioactive isotopes used are mostly 99 technetium or iodine 131 or gallium 67 or selenium 74. Then further we have advances in microbiological analysis. We have cultures. If you see a long standard up till now, right from the history till now, we have bacterial culture to be considered as gold standard under all the microbiologic identification methods, because of its, what do you say, sensitivity is better, or specificity is better. Then phase contrast or dark field microscopy, which is mostly used in certain to check up different conditions, you can say. Then immunoassays to detect immunoglobulin against bacterial antigens present in serum. You have certain immunoassays like immunofluorescent assays, which could be either direct or indirect. Then agglutination assays, which is mostly, the term itself suggests that agglutination, it is going to be agglutination of a binding of a protein to a latex bead so as to further detect the pathology. Then enzyme linked immunosorbent assay. We all know that ELISA is mostly used for detection of HIV. A membrane immunoassay adapted for a chairside clinical diagnostic use, also evalucite. If it is used in chairside, then it is called as evalucite. It also helps us to detect certain antigens like P. intermedia or Porphyromonas gingivalis or Aggregatibacter actinomycetum comitans. Then further, we also have cytofluorography or flow cytometry and enzymatic assays. The term itself suggests that enzymatic, it means that certain enzymes like N-benzoyl DL-arginine 2 naphthylamide BANA test or periocheck could be used. Certain enzymes could be used for detection of certain microbes, further to detect if the disease is present or not. Then molecular biology techniques like nucleic acid probes. In certain DNA technologies, we know that different specific microorganisms could be artificially synthesized, labeled for detection when placed with a plaque sample. So this probe sequences us to know if there is whole genomic DNA, and randomly clone the sequences of nucleic acids from the target bacteria, and thus further synthetic oligonucleotides that hybridize the 16S ribosomal RNA. Thus, we know that targets of DNA probe detection, the peridodontopathogens of AA, TF, PG, PI, and Streptococcus mutans group species. So, in office nucleic acid probe is Microprobe Corporation, mainly called as Omnigene, that is available. Then we have checkerboard DNA hybridization technology, which is developed by Sokransky et al. In 1994 for detection of different types of bacterial species found in the oral cavity. We also have certain newer technologies, which is a nucleic acid based assay called as PCR, polymerase chain reaction. If you could just go down a lane, you would just remember the COVID era. PCR was the most used uh, diagnostic testing that time. So we can just come to know the higher yield of replication of DNA thus, and better, extremely specific, extremely sensitive, and major limitation of being only qualitative. The modification of original PCR method, that is the real-time PCR assays, RT-PCR, was also used for during the COVID era for detection of specific bacteria. and or viruses. And also PCR is generally considered reliable when used in combination with certain synthetic 16S ribosomal RNA probes, which are highly specific to given species. Then we have certain commercially available diagnostic kits like PCR for certain different bacteria like P. gingivalis, AA, Tannerella forsythia, T. denticola, and P. intermedia, which is a microdent test. Then we have RT-PCR test, which is myperiopath, and we have diagnostic tests using the oligonucleotide microarray technology, which is SparrowCheck. It is a DNA chip that helps us detect 20, almost 20 periodontal pathogens associated with periodontitis, that is inflammation of gums. Or you have PhyloChip. Then we also have biosensors, which include various pathogenic bacteria that can reduce sulfates, thereby producing significant levels of volatile sulfur compounds, which give us a bad breath. And further, these compounds can be used to detect if there is any sulfide. These compounds can be used to detect if there is any type of halitosis or periodontal infection is there. Then we also have certain different diagnostic aids like PerioGuard or Pocket Watch, which assesses the certain levels of aspartate, AST in GCF, that is gingival crevicular fluid. Then PerioCheck, we have to detect neutral proteases in GCF. MMP, that is matrix metalloproteinase, which is a dipstick test used to assess MMP8 levels in saliva and GCF. Then prognostic and BioLyse to evaluate levels of elastase in GCF again. Then Perio 2000 or diamond probe to detect VSCs, that is volatile sulfur compound. Then Topaz to detect bacterial toxins and proteases. Then we also have advances in instruments like over a period of year, if you could just go down back the lane, we had only manual instruments which we had to be like very stringent about it. It could also hurt patient at times, or it could like require a lot of time to get done with the treatment. But over a period of years, we have developed into a powered toothbrush or something powered devices which can be used even at home and even in the office care. So at home you have something called as a water pick, which is a powered flossing device. Or you have water flosser or a dental water jet. Instead of manual flossing, you can use a water pick, or even the manual one is better till date. So you also have dental endoscope. Since you had detection of plaque and calculus, so plaque and calculus supragingivally can be visible with the eye. But what is about subgingivally? Subgingivally, you will need something called as endoscope or some different instruments, different diagnostic techniques to detect the subgingival part. So perioscopy is used for the subgingival part. It is nothing but a reusable fiber optic endoscope over which is fitted with a disposable sterile sheath. It fits into the periodontal probes and ultrasonic instruments that have been designed to accept it. The sheath further delivers water irrigation that flushes the pocket with the while the endoscope is being used, keeping the field clear. It attaches to a medical grade CCD video camera and a light source that produces an image on a flat panel monitor for viewing during subgingival exploration and instrumentation. The magnification ranges from 24x to 48x in perioscopy. Then you also have EVA prophylaxis system to for more efficient and less traumatic instruments for correcting overhanging and overcontoured proximal alloys. It has a motor driven wedge shaped diamond files in symmetric pairs of aluminium. Also, the wedge shaped file protrudes from a shaft, and one side of the wedge is diamond coated while the other is smooth for less traumatic procedure. Then you have air powdered polishing, so that commercially available is Profijet. It is nothing but you have certain different air powder polishers or powders like sodium bicarbonate, which can be used, or glycine can be used for removal of subgingival biofilm from the root surface. Then spectro-optical technology, which is detector. Certain technologies are used only for detection of plaque in calculus, but certain can be used for detection as well as removal. So these are certain, these calculus presence, you can say that it is indicated with audible luminous signal. So as I said, that subgingivally it is not visible with a naked eye. So what you can do is just insert this detector probe into the sulcus, and if there is any presence of calculus, it is going to give us audible luminous signals. If there is no calculus, no signals, and therefore no need of treatment. But in case there is calculus, so it will detect us with a signal, and then we can go ahead with oral prophylaxis. Then we have something called as autofluorescence based system. Oral microbes and their metabolites contain certain fluorophores that are emitted from dental calculus and caries lesions. The ability of a calculus to emit fluorescent light following irradiation with a light of a certain wavelength has been used in its detection, called as diagnodent. It is commercially available with the name of a diagnodent. Also, calculus is shown to develop a digital display as a relative calculus detection values from 0 to 99, and a beep whose intensity increases with the display value. Then further you have a perioscan, which can be used to detect as well as remove calculus. As I said, green light indicates cementum while blue indicates calculus. There is also additional sound signal that is heard when calculus is being detected. Then you also have laser technology, which is being used in periodontal therapies at a larger scale nowadays. And you have key laser, which combines calculus detection as well as calculus removal in a feedback controlled manner. So this key laser contains 655 nanometers indium gallium arsenide diode laser for calculus detection, along with a 2940 nanometers erbium YAG laser for calculus removal. So calculus detection, you have indium gallium arsenide, while calculus removal, you have erbium YAG. So both are going to show a threshold value once the calculus is detected and once it is removed. And everything is going to be done in a automatic way because it is laser. Then also you have certain called as certain microsurgical instruments that have been used, and if you could just see that magnification along with microsurgery could be like a heaven, next to heaven, literally. It could be a gold standard also in another coming years, or another decade. It could be a gold standard naturally. So it helps us to create clean incisions to prepare the wound for better healing by primary intention, because the incisions are established at a 90 degrees angle to the surface. The handles of microsurgical instruments are rounded and they have controlled rotating movements. The instruments are approximately 18 centimeters long and slightly heavy, top heavy, to facilitate accurate handling. Also, the weight of the instruments is less. It ranges from 15 to 20, and in order to avoid unfavorable metallic glare under the light of microscope, the instruments often have a color coating surface. So these microsurgical instruments can be used in opposed to the previous instruments for better healing. And micro, as I said, the size of the instrument is less, so the wound created would be less, and also the better healing because small wound is there. So we saw radiograph, microbiology instruments and everything, and now we have certain equipments. Like I said, lasers can be used in conjunction with blade, or just plain lasers can also be used for either non-surgical therapy, surgical therapy, decontamination or antimicrobial therapy, or biomodulation. It can also be used in implants. The present slide indicates that different types of surgical procedures which can be used in with a laser. So not only laser is just a good thing, but also you can see that it reduces the trauma, it reduces pain, it reduces your wound. Everything is good. So we discussed microsurgery. Again, a microsurgery is nothing but a microscope with you're working with a visual acuity is increased using a microscope, and you're working at magnification exceeding 10x. So it is a better ergonomics. So not only it is better for the patient because it's creating a smaller wound, but also it is better for the doctor since it is a ergonomic methodology, because you're sitting straight while you're working with a microscope or you're using loops. You need to have a proper distance between the loops or the microscope and the patient's tooth or the area which is your of the interest. So you can't just bend and your spine is benefited out of it. So this surely can be a ergonomic methodology. In a broader sense, we know that microsurgery implies an extension of surgical principles by which gentle handling of tissues and approximation of wound edges is of paramount importance. Then periodontal microsurgery, as I said, that it causes minimal trauma, more predictability, cosmetic results are better comfort level compared to conventional periodontal surgical procedures that are done with blade. As I said, the ergonomics of hand position, your body posture, improved motor skill, everything is better using either the loops or the microscope. So these can also help reduce surgical fatigue as well as spinal and occupational pathology common in periodontics. So this way, by using the microsurgical triad, magnification, illumination, instruments properly, which can help us with delicate tissue manipulation, we can also keep the orthopedic surgeons at a bay. Then, as I said, as I discussed earlier, the advantages and certain could be increased diagnostic skills, increased surgical quality, minimally invasive, less mobility, less patient anxiety, because your treatment is done at a faster time, less everything or traumatic management, so patients are happier. Also, there are certain disadvantages like you can't just start working. If you want to do microsurgery, you need to get trained for it. You need to start with like placing your loops and reading like a newspaper or a book. Then eventually you can start working on a chicken leg or something, and then you can go ahead with a non-surgical prophylaxis on a patient, and then the surgical. So you can't directly start placing your loops and start with the surgery. It can't happen like that. You need to give some time. Your eyes, your spine, your overall body has to adjust really with the loops, the microscope, and then you're going to have clinical proficiency with it. So there are different surgeries which can be done with minimally invasive techniques, that are minimally invasive surgeries. Like Harron and Rees first introduced MIS in periodontal literature to minimize flap reflection and trauma, resulting in maintenance of critical blood supply, stability of the blood clot within the wound site, and less postoperative recession over time. Also accomplished through the use of tiny incisions, sharp detection of soft tissues to gain access to the defect, and minimal suturing to avoid trauma to papillary tissues. So, along with MIS, it was MIST, which was proposed by Cortellani and Tonetti in 2007. It is used for papilla preservation procedures and small incision designs for surgical access in periodontal surgeries. Then you also have something called as MMIST, which was proposed by Cortellani et al. In 2009, which is a even less invasive modification of MIST that attempts to leave the interproximal tissues attached to the tooth root surface, thereby introducing an added dimension of stability and better interdental papilla healing would be seen with it. You also have single flap approach, which was given by Trombelli et al. In 2009. Single flap, the term itself suggests is that only one side of the flap is going to be reflected, either buccal or lingual, or buccal or palatal. Only one side is reflected, and it can be only done if you have certain intraosseous defects on certain side. If you have a three wall defect, some a two wall, a one wall defect, then you need to really see. It depends on which wall defect is seen and how much is the defect, whether it is vertical or horizontal, and different types of bone defects. According to that, you can like come to a conclusion whether you have to go ahead with a single flap approach or the conventional approach. So these are my references. And thank you. I would like to thank Coalesce Research Group and the Fifth International Oral Health and Dentistry Conference for giving me an opportunity to speak at a esteemed conference, and looking forward for more lectures. Thank you.
Thank you, Dr. Sariu, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Okay, thank you once again, Dr. Sariu, for your wonderful presentation.
Most
So,
welcome.
yeah, let's move on to the next presentation. It's a keynote presentation by Dr. Nazik Shaban Mustafa from International Islamic University, Malaysia. Hello, Dr. Nazik. Hello. So, we'll be sharing the screen from our end. So, after we share the screen, kindly let us know whether it is visible or not.
Okay.
Give us a moment, we will share it right away. Is your screen visible, Dr. Nazik?
It is visible. Can make it bigger or because I see it is okay with you? You can see it?
Yeah, yeah, it is perfect. It's full screen only.
Oh, okay, that's good. That's good. Okay.
Yeah, yeah.
Um, Good evening or good afternoon, maybe, because now it is the time near to be 8 p.m. In my area. My Thank you for the fifth dental health conference to giving me this opportunity. Actually, I will share to you with you today the topic, which is the recurring peripheral amyloblastoma at mandibular region. Actually, as we know that the peripheral, next please. We all know that the peripheral amyloblastoma is extraosseous type of amyloblastoma, which is in general amyloblastoma, the percentage is range 1% of tumor, oral tumor in general, while the amyloblastoma taking the 11th percentage of the all types of odontogenic tumor. Next, please. So the intraosseous is the more common, most common compared to the extraosseous, which is the peripheral amyloblastoma. The intraosseous is presented as a solid multi-cystic amyloblastoma, unicystic amyloblastoma, and multicystic. Actually, we all know that the radiographic appearance of this type of amyloblastoma is very similar sometimes in the to odontogenic keratocyst. Anyway, the peripheral amyloblastoma is extraosseous form of amyloblastoma, comprises of 2 to 10% of all non occurrence of amyloblastoma, and it is an exophytic growth that occurs on the soft tissue near the tooth-bearing areas of the jaw. Next, please. So the clinical presentation of this type of amyloblastoma is non-ulcerated lesion, which is sessile mainly, or sometimes it is pedunculated. It is painless, slowly growing, firm, exophytic, and in general, the clinical presentation of this type of tumor is a recurrence if there is a risk of recurrence is if it is not adequately removed. Not adequately removed, then there is a recurrence rate of this type and other type of ameloblastomas. Although these tumors do not infiltrate the bone, but it might be seen to cup out bone in the jaws. Next. Then what's the treatment of this type of the tumor? Definitely the treatment is local excision. Local excision by mean if the diagnosis confirmed yearly and the lesion is visible, definitely it's easy to go for direct excision, especially I am talking about the peripheral. Peripheral, since there is a lesion, the patient will seek a treatment plan and then will come to you to ask what is this? You give differential diagnosis, you give different diagnosis, and then you have to go thoroughly about the history from the patient, how long it takes to appear, is it a bleed or not, painful or not, all these questions you have to ask the patient, otherwise you will miss the diagnosis. And missing the diagnosis, actually, it means that missing the treatment plan, which I mentioned before, that it could be a recurrence of the lesion, and especially if the lesion is not treated properly. So local excision, when surgical margins are negative for a tumor, a cure is likely to be consequent. We don't have to worry if we do excision and there is no the surgical margin are negative, so you have to be almost sure that the recurrence is no. Malignant transformation of peripheral blastoma is very rare actually. Next please. Now, coming to the current scenario or case study, actually, this is a case study that we got and I have it treated, and we will see that the sequence, because the sequence of a treatment, actually, when there is a lesion in the oral cavity, even if it is ulcer, non-healed for more than 2 weeks, so we have to go for biopsy. So here there is a 37-year-old male presented to the clinic with the painless, slowly growing, firm yet sessile mass, measuring 2 cm by 1 and 2.2 cm in diameter, with finger-like surface projection located on the lingual region of 3.1 to 3.4 teeth area. So here we have painless swelling or growth, slowly growing, because the patient mentioned that he observed that long time ago, but it start to affect him during eating or start affect him during brushing. That's why the patient seek a treatment plan. Now we have to observe, we have to look at the lesion, give a primary diagnosis, ask more and more about the case, and then to reach the diagnosis. Definitely if the lesion is small, so we will go for excisional biopsy, while if it is a big, we will take a sample. In our case, we have done excisional biopsy, and by the way, the patient having this what we call sign and symptoms, but the patient is during examination, we have seen that the patient has no any problem with what we call the surrounding structure. I mean, the teeth are vital. The teeth are vital, and the teeth are vital, and the surrounding tissue of cervical area of and the submandibular cervical lymph node are all asymptomatic, no any pain, no any swelling extraorally, no any lymphadenopathy, and this is the whole scenario, in brief, the scenario of the case. Next, please. So as you see here, the lesion is lingually situated with no any problem with the surrounding structures, and there is no any problem with the teeth. The teeth are vital, and then we discuss with the patient about the treatment plan. As you see here, that the whole lesion is lingual side. The teeth, the surrounding teeth, are vital. Next, please. So, incidentally, as mentioned, all these things are negative, no any problem. Patient had no relevant medical history. Then we decided to do surgical removal of the lesion. Before that, definitely we go for further investigation, which are OPG as well as periapical radiograph, which showed an interdental spacing in between the 3332 teeth and a minimal horizontal bone loss, and having no clear sign of aggressive bone lesion. So until here, there is no effect on the surrounding structures, whether the bone or the teeth. Then we go for next, please, for surgical removal. So here, at this point, we have to set the differential diagnosis that what could be this lesion. Then accordingly, we go for doing surgical removal. Here, first of all, pyogenic granuloma, gingival apulus, periapical giant cell, peripheral or peripheral, that means the outside giant cell granuloma. All these were the differential diagnosis, the primary provisional diagnosis. The entire lesion was biopsy then in total under local anesthesia. Then the decision was to remove the lesion by excisional biopsy and sent for histopathological investigation. Next, please. Now, this, as we see that there is a histopathological examination stained by hemotoxylin eosine, there is the amyloblast-like cell, there is squamous metaplasia, and then there is all the stellate reticulum, and then you know that the origin of the amyloblastoma, it should be that odontogenic origin. So all these we have seen in the most important thing is the amyloblast-like cell, and in this case, the diagnosis according to the biopsy is amyloblastoma or peripheral amyloblastoma. Unfortunately, next please, the patient didn't manage to come for follow-up after removal of suturing of suture, and the patient didn't come for what we call the follow-up, and then in this case we were waiting for the patient to come for follow-up to see the progress. So final diagnosis, as mentioned, clinical, physical, radiographic, and histopathological all reveal that this is a peripheral amyloblastoma. But as I mentioned, that the patient didn't manage to come, and then he came 2 or 3 years after. Next, please. Then when the patient came this time, that means 3 years after, we see that unfortunately that the lesion recur, and the lesion, instead of lingual, it involved the labial gingiva. The swelling appears similar to its past presentation. This time, however, the mass has extended onto labial teeth surface of the gingiva of the 3-2 and 3-4. Next, please. By the examination, now we have seen that the patient got non-vital teeth. Non-vital teeth, in addition to that, slight mobility of the teeth. So this means that there is bone problem here, and the surrounding tissue of the teeth are affected by the lesion. So in this case, we discuss with the patient about redo the surgery, because the diagnosis, according to the diagnosis, the treatment plan should be a little bit different. Then the patient agreed about the surgery, and the surgery included the removal of the teeth, the involved teeth, with suturization, and all the whole lesion removed with the alveolus bone, and then alveolar process surrounding the teeth, and then with safety margin and the tissue sent for biopsy. Next, please. Next. Next, please. This is also the lesion, and here the labial area of the lesion. In addition to the lingual, the labial area is present here and surrounding the labial surface of the teeth. Next, please. Now, the X-ray have done showing there is radiolucency as in OPG, in periapical more clear. Next, please. Yeah, this is other view showing the exophytic of the lesion, which is lingual and labial. Next. These are the sockets after removal of the teeth. Here as well, we see. Then the sockets also, next please, seen. You see here the features of suturization with no penetration tissue tags during excision. And then we have here, this is the picture after the removal of the whole lesion. Next. Suturing. And next, the final one. This is the amyloblast-like cell, stellate reticulum, and squamous metaplasia. And you see here almost the same structures, same results of the biopsy, again from the histopathological pathology department, resembling that this is definitely a peripheral amyloblastoma. Next, please. This is the healing. 1 year after. and we see there is no any sign and symptoms or symptoms of the recurrence. Next, please. This is the X-ray 1 year after, and we see that clear bone, no any lesion, intrabony lesion, okay, and the teeth, surrounding teeth are vital with no mobility and no. Actually, temporarily, the patient is wearing denture to prepare for a future implant later. Next, please. This is the 3D model showing the aspect of the lesion after surgery. And then by this, actually, we got a follow-up after 1 year and after 6 months, 6 months, 1 year, and after that, the patient has no any complaint, no any sign and symptoms, no swelling, no any growth, and the patient successfully treated, and he is happy of the result of the treatment plan. Next, please. This is the CT scan also, just to confirm about the any lesion in the bone, any what we call changes happen. Everything is okay. Next. So actually, this is the references, and actually by this I want just to share the info about the examination and diagnosis, and we have to emphasize on the history of the patient, and in addition to medical history, definitely to proceed with any surgical procedure, but the diagnosis, the final diagnosis will be retrieved by the biopsy, and if there is, and the biopsy actually I mean the excisional biopsy here, because we have to wait and do follow up to see, unlike the incisional biopsy when we have the results and we proceed with what we call the surgical procedure, because here we have the what we call a lesion, none, and then we have to proceed accordingly, whether it is odontogenic, non-odontogenic keratocyst, or ameloblastic lesion, or any other pyogenic granuloma or whatever. So this according to the biopsy result. And excisional is different than incisional. This what happened, although the patient informed to come earlier for follow-up and he didn't come, or he didn't manage to come, and this is the result after that. By this, I would like to thank you again for all audience and for the conference for sharing this info. This is my faculty of dentistry in Malaysia, and by this, thank you very much to all.
Thank you, Dr. Nazi, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr. Nazik, for your wonderful presentation. And let's move
Thank
on
you.
to the next presentations. So the next presentation is by Dr. Rabab A. Al-Sabak from the Hama University, Syria. Hello, Dr. Rabab. Are you ready with your presentation? Hello, Dr. Rabab. Are you ready with your presentation?
Hello, yes, I'm ready.
Okay, so I'm making you as a presenter. Please click on the share button to share your screen. Please click on the share button to share your screen.
مش الحال.
Yes, your presentation is visible. Please make it a full screen and start your presentation. It's perfect.
Hello, everybody. Good evening for all. Great thanks and appreciation for the organization committee for this fifth international conference in dentistry and oral health. My lecture will be on evaluation of the effectiveness of platelet-rich plasma compared to the injectable platelet-rich fibrin on the rate of maxillary canal retraction, a three-arm randomized controlled trial. Me from University of Hama, Faculty of Dentistry, Department of Orthodontic and Dentofacial Orthopedics from Syria. These following data are related to PhD research done by Ali Ammar was completed under my supervision and published in the European Journal of Orthodontics a few months ago in this year. Shorter orthodontic treatment time is considered to be the main demand of adult patients who seek the treatment with less or no side effects. Compared to adolescents, adults have more bone density and less bone turnover. Besides, their periodontal ligament contains fewer cells, so adult patients suffer wider glass hyalinization areas inside the periodontal ligament, which need more time to transcend orthodontic movement phases, as well as they have higher root resorption during orthodontic treatment. Where we are, the available evidence, acceleration of orthodontic tooth movement to accelerate orthodontic tooth movement and surpass their limits, surgical and non-surgical techniques were described in the literature, such as regional acceleration phenomenon such as corticotomy, corticism, microosteoperforation, and which have in general high success rate, but they rely on injury on bone tissue. Most patients do not accept the intervention due to its aggressive nature and side effects that could happen to the target teeth. Also, the intervention requires help from another specialist and has a higher cost. So these techniques haven't gained popularity in every orthodontist clinics. Injection of different material, including prostaglandins, thromboxane, corticosteroids, parathyroid hormones, thyroxine, vitamin D. The mechanism of action related to the effect of these materials on osteometabolism process. However, later studies have shown that these treatments may lead to negative side effects, local and systemic, such as bone thinning, delayed wound healing, and root resorption, which had led to a reduction in their use. Physical techniques, including pulsed or static magnetic fields, electrical current, vibrations, low-level laser therapy. Many studies concluded that physical methods not very effective in the acceleration of orthodontic treatment. Or we still need for further well-designed trials to prove the ability of these methods in the acceleration of orthodontic tooth movement. Recently, it has been demonstrated that orthodontic tooth movement can be accelerated by using platelet-based preparations from the patient's own blood, such as platelet-rich plasma and platelet-rich fibrin. Platelet-rich plasma is obtained via centrifuge of patient's blood and defined as an autologous concentration of platelets in a small volume of plasma. The number of platelets about 150,000 to 450,000 units in liter of blood, whereas the number of platelets in PRP about 1 million. When the platelets in the PRP are activated, the granules are degranulated and release the growth factors such as cytokines, several important growth factors released by platelets in our PRP, like vascular endothelial growth factor with fibroblast, and in addition to insulin-like growth factor. About the drawing of PRP, blood draw about 20 ml from blood with a patient, and then a tube with anticoagulant material as acidic dextrose with as anticoagulant materials, and then adapted to centrifugation for the first time about speed 1000 per minute during 12 minutes. Then we have 3 layers formed. In the bottom of the tube, we have red blood cells, about 55%. In the middle, we have platelet-rich plasma, about 5%. And in the above of plastic, we have platelets poor plasma, about 40%. Then a drawing of the middle layer, which is rich with platelets without red blood cells, and then moving to new tube without anticoagulant, and then centrifugation for the second time about speed 3000 round per minute for duration 8 minutes. Then we'll have separation of platelets, poor and rich plasma immediately. And then we have the platelet, plasma rich in platelets and ready for injection. About injectable platelet-rich fibrin, PRF is defined as the second generation of blood-derived biological materials. Contrary to PRP or platelet-rich plasma, platelet-rich fibrin is prepared without the use of anticoagulant, and it is obtained by a single centrifugation of blood. PRF in its different types contains ingredients such as protease and antiprotease, which motivate the formation of new blood vessels and remodeling of the current blood vessels, beside cytokines, which are essential in bone and blood vessels formation. We draw about 20 milli from the patient, then tubes without anticoagulant materials, then undergo a centrifugation with speed 700 per minute for 3 minutes only. Then we will have 2 layers formation, red blood cells in the bottom of the tube, and we will have injectable platelet-rich fibrin in the above of the tube. Then we draw the upper layer, which is injectable platelet-rich fibrin, and it will be ready for injection. as mentioned by Myron. What are the differences between PRP and PRF? PRP, 2 stages, while PRF, 1 stage. We have anticoagulant in PRP. We have no anticoagulant in PRF. Growth factors release have large levels within short period of time in PRP, while in PRF we have constant levels for a long period of time. Finally, speed of preparation require higher speed in PRF than PRP. The problem with the current evidence, conflicting results have emerged about the effectiveness of blood-derived materials in accelerating orthodontic tooth movement. Leo, in his case series, concluded that one injection of PRP had a positive effect that lasted for 5 to 6 months, with the largest effect in the 2nd to 4th month after the injection. Whereas El-Timami and his colleagues in a split mouth trial reported that the 3rd month after injection showed a statistically significantly slower rate on the intervention side. Angel and his colleagues in their split mouth randomized controlled trial showed a significant increase of 35% in maxillary canine subtraction during the 1st month, which declined to 14% at the end of the 2nd month. Besides, the design of these trials was a split mouth, one which is not suitable because autologous platelet concentrates may trigger a systemic effect once injected in the oral mucosa, and the effect cannot be confirmed to be locally restricted. Reviewing the available literature indicates that only one randomized controlled clinical trial has compared the platelet-rich plasma with the injectable platelet-rich fibrin in terms of the rate of orthodontic tooth movement. The design of this experiment was a split mouth one, which is not suitable in this context because autologous platelet concentrates may trigger a systemic effect. In addition, they started the retraction after 14 days of extraction, which could interfere with the effect of PRP and injectable PRF. Furthermore, a recent systemic review about the effect of autologous platelet concentrates on orthodontic tooth movement emphasized the need for further randomized clinical trials. Aims of the study. The current trial was conducted to investigate whether the PRP and the injectable PRF affect orthodontic tooth movement and to compare these two platelet concentrates in terms of upper canine retraction rate. What did we do? Study design was a 3-arm parallel group randomized controlled trial. 60 patients divided in 3 equal groups. Group 1, PRP group, the second group, injectable PRF, and the third group, control group. Estimation of sample size was done by using G-power with the assumption of power of 90% with a permissible error of 5%. The smallest difference requiring detection in canine retraction was assumed to be 0.5 millimeter in mass with a standard deviation of 0.03 millimeter from a previous study, Al-Kipsi in 2018. In the year of 2018. A sample of 57 subjects was needed. 3 additional patients were included to consider sample attrition, and total sample size became 60 patients. Inclusion criteria were both male and adult female, aged from 18 to 25 years, class 2 div 1 malocclusion. Maxillary face premolars were removed as part of the treatment, complete permanent dentition, good oral and periodontal health. Exclusion criteria, we avoid severe skeletal clastomal occlusion, overjet less than 10 millimeter, and the AMB below 7 degrees. Illness and drugs that might have an impact on bone biology, inadequate oral hygiene, a previous orthodontic treatment, smoking cigarettes, finally having coagulation problems or taking anticoagulants. Information sheets were given and written informed consent was obtained from all the patient or their legal representatives. 20 patients received PRP injection, 20 patients received injectable PRF injection, 20 patients didn't receive any additional treatment. Minitab was used to regulate allocation of patients among the 3 groups using a set of random numbers with allocation ratio of equal groups. TPAs were used as anchorage devices. Then the patients were sent to extract the first upper molars by the same surgeon to eliminate the differences. Then we make leveling and alignment till we reach the 19 using MBT 22 inch slot bracket size until we finish leveling and alignment were accomplished until we reach 19 to 25 inch stainless steel arch wires was reached, and they lived another 3 additional 3 weeks to have passive arch wire. At this point, injections were first done in PRP and injectable PRF groups, and this was followed by a canine retraction procedures. We made a CBCT before retraction. PRP preparation. PRP, it's drawn 20 ml from the blood of the patient. Then PRP tubes with anticoagulant and anticoagulant as acid citrate dextrose were used after extracting 20 ml of venous blood from each patient. PRP was prepared with a double spin process mentioned by Marx. First time centrifusion about 1,000 per 12 minutes. We have 3 layers: red blood cells, platelet poor plasma, and the rich in the middle, and in the above the poor platelet rich poor plasma. The second stage of PRPE preparation using a double spin process, as mentioned by Marx. Then the second time centrifusion without any the first time we add anticoagulant, the second time we didn't add anticoagulants, and then had centrifusion about 8 minutes for 3,000 round in the minute. The separation of platelets of rich plasma, we in the second stage before centrifusion for the second time, we draw the red blood cells and we have the poor the platelet poor plasma and the mixed with the platelet rich plasma, and the second centrifusion, and then we have the platelet rich plasma and in the tube which have 10 milli and ready for injection. Injection was done on the distal surface of the upper canines and interligamentally in the middle, and then distobuccal and distopalatal, with 5 units in each area, in addition to buccal and palatal submucosal injections, 50 units respectively. The patients were injected immediately before canine retraction and after 8 weeks of the onset of the retraction. PRF preparation was prepared with the use of 20 milliliter of blood drawn from the patient into dry sterile tubes without anticoagulant quickly before coagulation starts. The centrifugal protocol requires 1 cycle only, 700 rounds per minute for 3 minutes only, as reported by Myron. We will have 2 layers, red blood cells in the bottom, and above the tube we have the rich fibrin, platelet rich fibrin. The prepared injectable platelet rich fibrin remained injectable for maximum 10 minutes to 15 minutes after centrifugation. We injected with injectable PRF immediately after centrifugation in our patients. Injection procedures, sites, units, and times was similar to the PRP group in the distobuccal and interligamentally in the middle, and distobuccal and distopalatal. We put nightie coil spring with 150 grams of force was applied to retract the upper canines, which extended from the band hook from the first molar to the canine hook of the bracket of the canine on both sides. A force gauge was used to check the generated force to guarantee a constant and equal force in all subjects. Patients had follow-up visits every 2 weeks. Each time the coil spring's force was assessed and, if necessary, readjusted to maintain at level 150 grams. The appliances were checked for any chewing-related deformation or displacement. Canine distalization continued until reaching class 1 canine relationship. Alginate impressions for the upper arches were taken before canine retraction, treatment 0, the first time, and every 4 weeks till the 16th week, we have 5 assessment times. Study models were made and scanned using 3 shape. 3 model were set in STL format. The 5 3D digital models were superimposed using orthoanalyzer software. The amount of canine distalization per month was estimated by calculating the distance between the canine cusp tip in the baseline model to the canine cusp tip in the subsequent superimposed model. We have T0 to T1 after 4 weeks, after 8 weeks, after 12 weeks, and after 16 weeks. What did we find? The amount of canine distalization, there were significant differences in the canine retraction. The control group was the lowest, and the the most canine retraction we obtained by PRF group. The rate of canine retraction was faster in the experimental groups in the PRP and PRF. The PRP group showed a significantly slower movement in the second and fourth month than the injectable PRF, while in the first and third months there were non-significant differences between the two experimental groups. The acceleration rate was 28% in the PRP group, 50% in the injectable PRF group than the control group. No harms were detected during the course of this trial. No complications were encountered during the injection of the tested materials. Factors may play a role during interpretation of the results. To our knowledge, the current study is the first 3-arm randomized controlled clinical trials evaluating the effectiveness of injecting the PRP versus the injectable PRF on the orthodontic tooth movement when retracting upper canines in extraction-based treatments. Age is a significant factor affecting the biological response to orthodontic tooth movement, and it is well documented that adult patients have a significantly slower rate of tooth movement. This might be attributed to the tissue response to orthodontic forces involving both cell mobilization and conversion of collagen fibers that are slower in adults than in children and teenagers. In a study employing leukocytes and platelet-rich fibrin in periodontally accelerated osteogenic orthodontics, Munoz and his colleagues had a wide age range from 15 to 51 years, which could affect the accuracy of the results. While in this study, adult patients aged from 18 to 25 years were chosen to reduce the effect of age on the rate of tooth movement. Tooth extraction can raise inflammatory markers activity, which can interfere with the effect of PRP and PRF. To decrease this probability, the extraction was made at the start of the therapy before leveling and alignment. Acid citrate dextrose, trisodium citrate, heparin, and common anticoagulants used for many different purposes for preparation of blood components. When compared to acid citrate dextrose, the anticoagulant has been found to be 10% less effective in maintaining platelet viability. Liet and his colleagues discovered that acid ACD anticoagulant outperformed TSC and heparin in preserving the integrity of the platelet membrane. Therefore, the ACD anticoagulant was used in this work as selecting the appropriate anticoagulant as an essential step in the preparation of the PRP. Placebo injections could have been used in the control group to simulate what would happen in the other two groups regarding periodontal ligament tissue damage caused by the injection and its effect on orthodontic tooth movement. But for ethical reasons, placebo injections were not used, since the main purpose of this trial was to compare the effects of PRP and injectable PRF on orthodontic tooth movement. It seems that the PRP injection effect lasted only for 1 month, as the canine movement returned to a lower level of speed in the second and fourth months. This might be related to the short effect of PRP. In the injectable PRF group, the increased rate of canine retraction was significant at all time points during the 4 months period when compared with the control group, and that could be explained by the long-lasting effect of of injectable PRF, as a new study has shown that new forms of PRF have gradual secretion, natural and gradual secretion of growth factors. Unlike PRP, PRF comes from a natural and a gradual polymerization that takes place during centrifugation. The resulting fibrin network has an especially homogeneous three-dimensional organization, and this fibrin matrix has the capacity to store the proteins within it, allowing the slower release of growth factors over time. Furthermore, polymerization must suggest a greater incorporation of circulating cytokines into the fibrin, such as configuration proposes that these cytokines will live longer since they will not be emitted and utilized during the first stage and will enhance bone remodeling. Limitation of this study, blinding of the researcher was not possible in the current study during the clinical stage period, as the investigator was able to know the type of the injected substance, PRP or injectable PRF, which may have increased the possibility of bias. Patients in the control group didn't receive placebo injections, which could affect orthodontic movement due to the tissue damage caused by the injection, especially regarding periodontal ligament injections. This study was a 4-month observation period. Only 2 injections were delivered throughout that period. Therefore, multi-arm studies with longer observation time to compare different injection protocols, maybe 1, 2, 3, or even 4 injections are needed in future research work to study the effects of repeated injections during orthodontic treatment. We conclude within the limitation of the current study, we conclude that during canine retraction, the use of platelet-rich plasma and injectable platelet-rich fibrin was a successful way to accelerate orthodontic tooth movement. The PRP effect lasted for 1 month only, while the injectable platelet-rich fibrin had a prolonged acceleration effect. We have this case, class 2 div 1, canine class 2. We have overjet less than 10 degrees. And then we have TPA, then extract, then have leveling till we reach the 19 to 25 stainless steel. Then we started to inject before canine retraction, which retracted by coil spring. And then we have another injection after 8 weeks. In this progress of this case, we noticed the retraction of the canines and this fourth step, and in the final results, we have good results, good overjet, overbite, canine class 1 canine relationship, and good details in occlusion. Thank you for your attention, and we wish you to success in this conference and progress in dentistry.
Thank you, Dr. Rabab, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr. Rabab, for your wonderful presentation.
Thank you for you.
Thank you. Thank you very much. Okay, we are moving further with the further presentations. So the next presentation is a poster presentation by Dr. Salva McLeod from Kongbuk School of Dental Medicine, Temple University, United States of America. Hello, Dr. Salva. Are you ready with your presentation? Hello, Dr. Salva. Are you ready with your presentation? Okay, so I'm making you the presenter. Please click on the share button to share your screen. Hello, Dr. Salva. Your PPT is visible. Please make it a full screen and start your presentation. We are unable to hear you. Kindly check it with your um, headphone settings, audio settings. Your screen was perfect, but we are unable to hear you. Your audio is not. Hello, Dr. Salva McLeod. Can you hear me? Please unmute yourself. Yeah, we are unable to hear you. Kindly check your microphone settings.
This conference will now be recorded.
Okay, so I'm sorry about that, everybody, but maybe I have some, microphone issues here. So today I will talk about the effect of thickness and background shade on the final color of zirconia veneers. So there I have some colleagues who actually helped me with that research. So that's why I had to gives them also some credit. So as we all know, zirconia actually become very popular ceramic because of its aesthetic outcomes, biocompatibility, toughness, and also low production cost. Increasing the thickness of zirconia restoration can decrease the translucency, but increases the background masking properties. And this will help us actually to understand the effect of the background on the final shade of zirconia veneers. So for clinicians, they should actually evaluate the shade color barrier to the selecting the shade and the thickness of the final zirconia restoration in order to obtain the desired final shade. So the objective was to investigate the final shade of zirconia veneers with 3 different thicknesses over teeth with 4 different shades, and also to highlight the effect of background shade on the veneer shade selection. So material and the methods that we used, we did 75 chairside CAD/CAM shade A1 zirconia veneers with thicknesses 0.5 mm, 0.72 mm, and 1 mm thicknesses. They were evaluated for final shade over resin composite tees with shades A1, A2, A3, A3.5, and A4. Veneers were then divided in groups according to the thickness and background shade. Then all restoration on teeth with different shade were evaluated with a color imaging spectrometer to map the veneer surface from A1 to D4. So we got some interesting result. So all veneers, regardless of the thickness and the background shade, presented shade alteration from the original color. A1 shade veneers with 0.5 mm thickness tended to display B1 shade. Veneers with 0.75 mm thicknesses primarily exhibited B2 shade. Veneers with 1 mm thicknesses primarily displays B2 shade. And here is a screenshot of actually the result that we got. And we used Kirkcell Wallace testing and followed by Banoffee actually correction, and then after that we did actually a linear regression model. And this table showed the distribution of the subshades according to the background. And this is actually also a sample of the screenshots that we actually get from using the SpectroShade. And this is like a map that shows the distributions of each color of each shade that we got after we actually added those veneers to the resin dyes that we used. So our conclusion was the thickness of the veneer and the background shade can actually modify the original shade of zirconia veneer. Thinner restoration showed higher values obtained with the color imaging spectrometer. And this is just the references of what we used. And that was my presentation. We're still working on some more actually presentation to study more the effect of the veneers on the translucency by itself. And I will just keep you guys updated of the new results that we might get.
Thank you, Dr. Salva McLeod, for your wonderful presentation. Does anyone
Thank
have
you
any
so much.
query?
My honor. Thank you for being here.
Does anyone have any queries?
Thank you so much.
Hope there are no queries. Thank you once again, Dr. Salva McLeod, for your wonderful presentation.
Thank you so
Okay,
much.
Thank you. So let's move forward with the further presentations. So the next presentation is a poster presentation by Dr. Hina Nirmal, Learn for Success from United Kingdom.
Specialty dentist in oral surgery in the UK, and I am presenting our poster presentation that I have done alongside my colleagues, Coalesce Ibrahim, who is a dental nurse, and another senior dentist.
Hello everyone, my name is Hina Nirmal and I'm currently working as a specialty dentist in oral surgery in the UK, and
I'm presenting a poster presentation that I have done alongside my colleagues, Coalesce Ibrahim, who is a dental nurse, and another senior dentist whose name is Rabina Khan. The title of our poster presentation is Assessing Oral Health Awareness and Motivation in Young Adult Vapers. Apologies, I'm not able to present live, but this presentation is for the 5th International Conference on Dentistry and Oral Health on the 14th of November 2023. As we know, vaping poses unique health risks to young people, primarily due to their vulnerability to nicotine addiction and the potential for long-term health consequences. It is essential for patients, educators, healthcare professionals, and policymakers to work together to educate young people about the risks associated with vaping, regulate the industry, and provide the necessary support for those who wish to quit vaping. During this presentation, I will cover and explore the impact on vaping on oral health, knowledge, and motivations of young adults. And hopefully on your screens you can see the poster we have created. The main purpose of this study is as a call to action, advocating for the development of education initiatives aimed at empowering young adult vapers to make informed choices regarding their oral health. We'll address knowledge gaps and understanding motivations. Our research aims to safeguard the oral well-being of this demographic within the ever-evolving landscape of vaping trends. Our research provides valuable insights into the dynamics of oral health awareness and motivations among young adult vapers, emphasizing the importance of informed decision-making and comprehensive oral health education within this context. Moving on to our methodology, our study design was conducted as a cross-sectional study targeting young adult vapers aged between 18 to 30. We used purposive sampling to recruit participants from various vaping communities, universities, and popular hangout spots. We employed a validated questionnaire to collect data on demographics, vaping habits, awareness of oral health issues, reasons for vaping, and actions taken in response to oral health concerns. For our data collection method, we structured face-to-face interviews, which we kept short, between 5 to 7 minutes, and used visual aids to enhance understanding. Interviews took place in familiar locations like vaping lounges, universities, and cafes. To analyze our data, we looked at the responses, generating descriptive statistics for demographics and vaping patterns. We'll use Fisher's exact tests to assess associations between knowledge, motivations, and actions related to oral health. In terms of ethical considerations, participants were informed about the study's purpose and gave verbal or written consent. We assured them of anonymity and the confidentiality of their responses. Moving on to results. In terms of demographics, the surveyed group, aged 18 to 30, was mostly female, with varying educational levels. Regards to their vaping behavior, most had vaped for around 3 years, with high daily frequency. This is likely due to peer influence, societal acceptance, and curiosity driving the initiation. A few saw vaping as distinct from smoking. Many encountered vaping content on TikTok, Twitter, and Instagram, and it has been glamorized but also seen as risky. Many were unaware of vaping's oral health impact. Those with symptoms reported dry mouth, gum bleeding, and tooth discoloration. Friends and social media were primary sources of awareness. Looking closely at health measures, some had switched to lower nicotine e-liquids or limited flavors. Dental checkup frequencies saw a minor increase, and few considered traditional cessation aids. Looking at influential factors, personal preference and peer recommendations mattered more than marketing and e-liquid choices. Participants didn't see a strong link between e-liquid flavors and dental issues. Now moving on to analysis, please have a look at the graphs on the poster. You can see graph 1, which demonstrates the factor that influenced decision making to smoke or vape the most. Looking at the options where strongly agree was chosen most, these include trend participation, educational gaps, stress management, and also perceived risk reduction to help reduce smoking cigarettes. Now if you take a look at graph 2, in our analysis section, factors influencing your decision to start vaping, where they were given the chance to select all that apply, the majority selected stress management, with 22% surveyed selecting this option. Thank you for your time so far. I'm just moving on to the conclusion. So the overall study objective was to explore why young adults vape and the awareness of oral health risks. Our key findings include that many participants lack knowledge about oral health risks from vaping, despite experiencing symptoms like dry mouth and gum issues. Factors like social acceptance and appealing e-liquid flavors influence their vaping choices, sometimes minimizing health concerns. Social media's positive portrayal of vaping further shapes their perceptions. Some participants acknowledged health concerns but lacked a holistic approach to oral care. In conclusion, young adults' vaping behavior is shaped by societal influences, personal preferences, and peer interactions. Bridging the knowledge gap and providing actionable information is crucial for better oral health decisions among young vapers. Thank you for taking the time to listen to our poster presentation. Any questions or further inquiries are welcome via email to hina.nirmal@uhbw.nhs.uk. All relevant references can be found at the bottom of our poster, and thank you once again for your time and enjoy the rest of your day.
And that is a poster presentation by Dr. Hina Nirmal. For any queries regarding the presentation, you can reach our program manager through email. By this, we are moving on to the next presentation. The next presentation is by Dr. Manju Saraswati from Sri Chitra Thirunal Institute for Medical Sciences and Technology, India. Hello, Dr. Manju. Are you ready with your presentation?
Yeah. Can you hear me?
Yes, you're audible. So I'm making you as a presenter. Please click on the share button to share your screen.
Is the slide visible?
Yes, your screen is visible. Please go ahead with your presentation.
Yeah. Good afternoon, all of you. So the topic I'm going to discuss today is the development of mucoadhesive bandages for oral drug delivery application. So myself, I'm Manju from Division of Dental Products in the Department of Biomaterial Science and Technology in Biomedical Technology Wing of Sri Chitra Thirunal Institute for Medical Sciences and Technology. So before going to the topic, I would like to give a small introduction about our institute. So the slides are not moving.
Hello.
Yeah, the slides are not moving. Just a minute. Please
Okay.
excuse me. I'm not sure why this one. Slides are not moving. I'm not sure why it is.
Hello.
Yeah,
Hello, Dr.
actually,
Manju.
I'm facing some difficulties.
In moving the
My
slides.
slides are not moving. Is it moving right now?
They're moving right now. Please make it a full screen.
Mm-hmm.
Please click on the slideshow option at the bottom right corner.
Is it in the full screen right now?
Not
Hello.
yet. Hello, Dr. Manju. Yes, not yet, but let me check. Hello, Dr. Manju. Kindly click on the slideshow option once again.
I'm not showing. It's not showing the slideshow option. I'm not sure why it is. Actually, I'm using the online version, not the. I didn't have downloaded the app. I don't know whether it is because of that or not. But is it okay if I do like that? But it's not moving
No,
on the
you
screen.
have to download the PPT first and then open the PPT through your file.
Just excuse me. I'm really sorry
Okay,
for
okay.
that.
It's okay.
Now it's
This
okay. Let's
conference
move
will
into.
now be recorded.
So good news. I'm really sorry for the technical issue that happened during the talk. So before going to the topic, I would like to introduce the institute. So I'm from Sri Chitra Tirunal Institute for Medical Sciences and Technology in Trivandrum. That is the southern state of India, called Kerala. And the institute is an institute of national importance with the status of university by the Act of Parliament in 1980. And we have three wings, like medical hospitals, and it's a tertiary referral center for cardiovascular and neurological diseases, and Achita Menon Center for Public Health, and it's concentrating on the training and research in public health, and biomedical technology wing, that's focused on medical device development and biomedical technology translation. And we offer many academic courses, including postdoctoral, doctoral studies, and PG programs, and also PG diploma programs in medical, in medicine, and in public health, and also in basic research. We also have joined PhD programs and MTech programs with IIT Madras and CMC Velu. So I'm coming from Biomedical Technology wing of Sri Chitra Tirunal Institute for Medical Sciences and Technology, and from the Department of Biomaterial Science and Technology. And we have three different divisions within the department, and I'm from Division of Dental Products. And also we have many devices we have developed, and most of them, few of them are already transferred, and some of them are commercialized very successfully. And among them, blood bags and Chitra hardwalls are two of the very successful products from Sri Chitra Tirunal Institute for Medical Sciences and Technology. And the blood bag nowadays means we have like 30 million bags we are selling annually, and in different countries, and exported to more than 70 countries, this blood bag. And one of the main industry that is manufacturing this blood bag is Thermo Penpon. And the Chitra heart valve also, we have crossed 1,20,000 implantation, and with successful implantation with no structural dysfunctions reported till date. And other than the blood bags and heart valves, there are many other products we already commercialized and it's in the market, like vein viewer, baby warmer,
Hello,
and
Hello, Dr. Manju. Sorry for the interruption. Your slides are not moving. Kindly move your slides while giving the talk.
yeah, actually I'm moving. It's not moving?
Yeah, it's not moving from our end.
I'm not
Can
sure
you?
why.
Okay,
Uh,
kindly
uh, uh,
stop share your screen and then again share your screen while selecting the share
what
option.
about now? What about now? Is it moving?
Now they are moving, but while you're
Okay.
giving the
Okay.
lecture, they are not
Let
moving.
me let me choose this option. Let's. I think now it will be okay.
Okay, then.
Okay.
Yeah, now they are moving.
Okay,
Yes,
okay.
thank you.
I'm really sorry. Actually, I don't know why it is happening. I'm sorry. So this is actually this is a new platform. Actually, go to is this is the first time I'm using this platform. Maybe because of that difficulties is coming. I'm really sorry. Anyway, so yeah, so these are the blood bags and Chitra hardware that is marketed from that is developed. The technologies are developed from our institute and marketed, and it is successfully commercialized. And nowadays, it's being exported. The blood bags are exported in more than 70 countries, and even prosthetic heart valve almost like 1,20,000 implantations are already done. And these are the some of the other products that is already marketed, including like prosthetic blood including like Chitra vein viewer, the warmer, and Accolosop respiratory secretion solidification system. And this is like wound dressing material based on the chitosan, and also the other polysaccharide material. These are the strains. So there are many technologies that is developed, and some of them are already commercialized. Some of them are in the stage of technology transfer and different stage. And other than the technology development activities, we are also concentrating on the testing and calibration services, and we are offering testing services based on the COFRAC accreditation and also the NABL accredited testing services. And we follow ISO 17025 for the biological evaluation of most of our testing, and also we follow ISO 13485 for the medical device design and development. So if any one of you are interested to do any physiochemical or biological evaluation of the material, we can offer testing services with in payment basis, and they can contact us. And coming to the topic, so the mucoadhesive bandages for oral drug delivery. So as an introduction, as you all know, the oral drug delivery, oral route is the most common route for drug administration, and it is the most preferred route because of its non-invasiveness, patient compliance, and conveniences. There are different factors that affect the oral drug delivery, including the drug residence time, mucosal permeability, stability in the gastrointestinal tract, and drug concentration or its solubility. And because of that, there are a lot of hurdles when it comes to the localized drug delivery and also in the systematic drug delivery. And here we are concentrating on localized oral drug delivery systems. So there are different drug delivery devices are available in the market in the form of gel, patches, spray, tablet, powders, etc. And some of the marketed formulation, oral localized to oral drug delivery formulations are like periochip, adistin, etridox, and actisite with the different compositions. So here we are as I already told, we are concentrating on the localized oral drug delivery devices. So when it comes to localized oral drug delivery devices, as mentioned earlier, there are multiple gel formulations for the treatment of various oral disease conditions are available in the market. However, the retention of this drug in the target gingival region is challenging because of a lot of hurdles like saliva. So it can come means this that means saliva and the use of water, frequent use of intake of water or food means these drug formulations will come out very easily. So there is a massive need for formulations that can enhance the retention of drug in the target region. So that is why we are concentrating on developing mucoadhesive drug eluting bandages that can enhance the retention of medication in the oral environment for a period of 8 hours to 24 hours. So whatever the gel formulation that is available in the market can come out within come out very easily, and we have to frequently apply, maybe like we have to apply within every half an hour or something like that, depending upon the severity of the condition. So if we have a patch that can hold the drug and release the drug for a period of time, that will be very useful, and it can be applicable for many localized oral disease conditions like desquamative gingivitis, oral ulcers, oral candidiasis, oral cancers, leukoplakia, pain after surgical perforations, etc. So here we are concentrating on using the mucoadhesive polymers for developing the bandages, and there are multiple mucoadhesive polymers are available, and people are using it for different applications. Example, gel and gum, cellulose, and its derivatives, chitosan, pectin, hyaluronic acid, alginate, etc., etc. Even though it has these mucoadhesive properties, we can even improve the mucoadhesive properties of this system by different chemical methods. So the objective of this presentation is to develop a mucoadhesive bandage for localized treatment for oral disease conditions such as desquamative gingivitis or oral candidiasis, and this is a schematic of our product. So coming to the methodology, so as I mentioned, means there are different mucoadhesive polymers are available, but still the mucoadhesive properties of those polymers are not that effective. That is why these gel systems are coming out very easily. So we would like to improve the mucoadhesive properties of this polymer system first before designing the product. So for that we have like modified using L-cysteine. We have to introduce the thiol moieties to the polymer so that we can have enhanced mucoadhesive properties of the native, the polymer itself. For that we use like EDC carbodiamide chemistry using EDC NHS and at pH 8.5, and we have stirred out the reaction mixture for a period of 24 hours. After completing the 24 hours of reaction, we have dialyzed the system in order to using a molecular weight cutoff dialysis membrane of 14 kDa in order to get out of all these unreacted monomers like L-cysteine and other reagent. So after that, after dialysis, we have cross-linked these thiolated polymers using different cross-linking agent, and also while it is cross-linking, we also added the drug molecule of interest. So for different disease conditions, we can choose different drug. Here we have used the lidocaine and triamcinolone acetonide as the drug combinations, and after cross-linking, we pour the cross-linked gel system in the Petri plate and evaporated the solvent by simple solvent air drying method. And once it is dried, we can peel out the films. And when we have dilated the gel and gum, we have used different feed ratios of the polymer and L-cysteine so that we can introduce different ratios of thiol moieties onto the polymer, and after that we have So in the system, as I mentioned in the schematic, it's like a three-layer system with the mucoadhesive layer and drug reservoir layer, and another is the backing layer, the hydrophobic backing layer. So the drug reservoir layer and the mucoadhesive layer, we have used the same technique. The drug reservoir, we have used dilated gel and gum along with the drug, and for the mucoadhesive layer, we have used only the cross-linked dilated gel polymer systems. So for the backing layer, actually we use the polycaprolactone that is more hydrophobic, and we use the electrospinning technique in order to make the sheets for the backing layer. And these are the different conditions that used to spin the polycapron layer with the optimum porosity and other characteristics like a voltage of 10.5 kV and the flow rate of 1.5 ml per hour, and the distance between the syringe and the receiver screen is around 12 centimeter, and the syringe diameter of 14.3. So by changing the different conditions of the electrospinning parameters, we can have different porosity, different alignment, different diameter of the fiber. So everything changes depending upon how we what is the condition of the electrospinning technique that we used. So the finally we have obtained three different layers, and that the mucoadhesive layer that we have obtained is having a thickness of 0.014, and the reservoir layer with a thickness 0.021 mm, and the PCL backing layer with the 0.011 mm. And the bandage as a whole, we have a thickness of 0.047. So we have combined these three layers, sandwiched these three layers by applying the pressure and a small and at elevated temperature we applied pressure in order to get this sandwich bandage. So coming to the results and discussions and the evaluations, and so first actually after preparing the thiolated gelangum solution, we have studied using FTIR, that is Fourier transform infrared spectroscopy, to see that means whether the thiolation is happened or not. So we can see that for the bare systems, there is no peak around 2520. So after the thiolation, and depending upon the extent of thiolation, um, we have a peak at 2520, that is for the SH stretching frequency of L16 moieties, and that the intensity of that peak is also changing depending upon the feed ratio or the extent of thiolation, as you can see from the graph that is highlighted. And we also checked the thiol estimation of this product using product, and we can see that means we use different feed ratios like 1 is to 0.5 and of polymer and L16, 1 is to 1 polymer L16, 1 is to 2, and polymer to 1:16 ratio. And for 1 is to 2, we used different mediums like PBS and water and at different pH, and we obtained that means as the feed ratio increases, or if we use the higher ratio of polymer to L16, we have a high extent of thiolation. Is the reactivity is means lot of thiol groups are introduced in the systems, and we also noticed that when we did the reaction in water, the extent of thiolations were very high compared to the PBS. It may be because of the salt concentration, there may be a lot of interference for the reaction. And again, we have to see that in order to confirm the thiolation is happened and how the rheological property of the system, we did the rheological study using the rheometer, and we can see that means as the extent of thiolation, so extent of thiolation increases from 0.5 to 1 is to 1 to 1 is to 2. So the viscosity is also increasing. And also another thing we can notice from the graph, the first graph, is that means as the shear rate increases in all these cases, the viscosity is drastically reducing. So we can conclude that means as in the case of GG 1:2, where the extent of dilation is high compared to other two systems, means there are a lot of thiol groups are introduced in the polymer backbone, and because of that hydrophilic thiol group, means there is a possibility of intermolecular intramolecular interaction between the polymer chains that itself increases the viscosity of the system. So that itself is a confirmation that the reaction is happened. And also means we also check that at different temperature means how the system looks like. So the second graph is about means the viscosity of the different dilated Jalangam systems, means at a shear rate of zero point 0.1 per second and at different temperature. And we can see that means for 1:2 the viscosity is very high. And also we can get an information from this graph is that means as the temperature increases, the viscosity is also reducing in all these cases. So that means the temperature is inversely proportional to the viscosity. Here, so we also did means what is the means when it is when the bandage is putting it in the oral cavity or in the gum or in the mucosal membrane, means if it swell too much we can't use it, and if there is less swelling, that is also a problem because it will also affect the drug release kinetics. And also in order to check the how the swelling capacity of these bandages, or if the sandwich film, we did free swelling studies. And we did it in both distilled water and in saliva, and also we have to do it in artificial saline, but because of the viscosity and all, means we are not able to do the swelling studies in artificial saliva. But the saline itself will have a give a stimulated data for this particular experiment. So we can see that the free swelling capacity decreases with the increase in percentage cross-linking. So here actually it is like a free swelling capacity with respect to increasing swelling. So we use aluminum ammonium sulfate as a cross-linking agent, and here the ionic cross-linking is happening, and we use to 2 weight percentage, 5 weight percentage, 10 weight percentage, and 15, 20 weight percentage aluminum ammonium sulfate as a cross-linker to see that how it behaves. And we can see that as the cross-linking increases, the swelling is also decreasing, and that is expected. And in the case of when it in saline, the swelling, there is no significant changes in the swelling characteristics. And in when we consider the whole all five systems actually, means compared to the swelling in distilled water, in saline the swelling is uh, there is a reduced swelling, and that is also expected because it's like in saline there are a lot of ions are present that will hinder the osmosis process. So but in the case of distilled water, means that is an advantage, means there will be swelling, high swelling, because of the absence of any ions in it. So we also check how means how the hydrophilicity or the hydrophilicity of the mucodacy layer and the backing layer of the system by using contact angle measurement. And we can see that the first picture, that is the picture A, is the contact angle measurement of the photo of mucodacy layer. And as expected, because it's a polysaccharide, the gelangum based system, and the gelangum is mostly hydrophilic. And whatever the sheets we have developed by cross-linking with the cross-linking agent, it should also have the hydrophilic in nature. And we can see that the theta value is around theta value is around 89 degree. It's in the more hydrophilic region. And with the PCl, polycaprolactone, means the contact angle is coming around 118, that is more towards the hydrophobic region. And the graph C is the quantitative measurement of A and B. Um, So, and our aim is also to introduce an hydrophobic backing layer. So, even we are using like a hydrophobic polycaprolactone depending upon the porosity and all other factors. Means the hydrophobicity can be changed. So here actually the value 118 is significantly good, and we can have significant backing effect, or there will be a resistance. It will resist the flow of this drug molecule towards the outer layer. So that is what our aim is, also to block the flow, and we have to introduce a unidirectional flow of drug molecule to the oral environment. And we also check how the strength of the strength of the mucoadhesive membranes. So we should have sufficient strength in order to withstand this membrane in the oral cavity or during the handling. So we check the tensile strength of this mucoadhesive, the three-layer sandwich mucoadhesive membrane in dry and the wet condition. In the dry condition, we got a tensile strength of around 30 megapascal, and when it is wet, after swelling, we introduce more. It become more fragile, and the tensile strength is also reducing, and it's coming around 2 megapascal. But still, it is good enough because it's having a strength of 2 megapascal. That means it's around 2000. It's around it's around um, 2000 kilopascal. So it's a good enough for the particular applications. We also checked means what is the folding endurance of the membrane by using by folding and defolding at multiple times. Here used means more than 1000 times we folded and defolded the membrane, and it's not, there is no the film is not broken, and that means it's highly flexible membrane, and it is mainly because we have optimized a different composition, even in order to introduce that flexibility, or the of the membrane. We have different composition, different additives are added into the bandage at different layers of the bandage. And for example, we have introduced a glycerin as plasticizer in one of the mucoadhesive membrane systems to introduce that flexibility. And again, we have to study, that means how the mucoadhesive. So this is like we develop the mucoadhesive membrane for the oral application. So even as I mentioned, there are oral formulations, and but that oral formulations are not sticking into the in the oral cavity for a period of time. It may be because it is interfering with the mucoadhesion of the it having less mucoadhesive properties. So we have to see, that means after modifying our mucoadhesive layers with or mucoadhesive polymers with different extent of dilation, and making it a film by cross-linking it with aluminum ammonium sulfate, how the mucoadhesive properties of that mucoadhesive layer will be. So we used the rat intestinal mucosa, and also the pig oral mucosa also we have used in order to study the mucoadhesive properties of the system, using the tensile texture analyzer, using the texture and using the texture analyzer, and we have seen that means as the extent of dilation increases from zero point 0.5 to 2 means the mucoadhesive property of the system is also increased, and we got a value around 350. The force of mucoadhesive force is around 350 gram. So compared to a PVA, polyvinyl alcohol control, means it's coming less than 50 gram in the bare PVA, and the dilated PVA it is coming around 100 gram, but it has a very high standard deviation, so the more sample has to be done in order to get a better a significant values, but still these values are very promising, and as it is having a very high mucoadhesive force. um, even the chitosan or other polymer, the polysaccharides means they are getting a mucoadhesive force of around 100 G only. So this system is very promising for this particular application. And we also check the cytotoxicity of this the film using L929 mouse fibroblast cells, because it's simply a basic cytotoxicity test to see that means whether it is toxic or not. So definitely we have to do with the cell line that is more suitable for this application. Here it's a basic study. We use the L929 mouse fibroblast cells based on the ISO standard, and we got that it is having, there is no significant toxicity uh, um, uh, in this films after before and after at different extent of dilation. And here the NC is the negative control and the PC is the positive control. So positive control means it's very toxic, and NC means negative control, that is non-toxic. So our system is also coming in the range of non-toxic systems. So, in concluding, we have developed the mucoadhesive bandages having three-layer system is very effective, and it has, we have evaluated different physiochemical characterizations like mechanical properties, holding endurance, and its dilation and the mucoadhesive properties, and all it was means it's a promising application of this. The three-layer sandwich bandage. And we also confirmed that the high mucoadhesive properties of this film and the sandwich film were confirmed using different mucosal tissues via ex vivo experiment. Here we like rat intestinal mucosa or the pig oral mucosa, but the value of the pig oral mucosa I am not shown here, but that's also giving a very good it's also showing a significant improvement in the mucoadhesive properties after this modification. So um, I also acknowledge many of our staff and for completing the successful completion of the work. And thank you for your patient listening. And I'm happy to answer any of your questions. Thank you.
Thank you, Dr. Manju, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr. Manju, for your wonderful presentation.
Thank you. Thank you so much.
Okay. And by this, we come to the end of day 2 webinar. I would like to thank all the attendees and participants of today's webinar. Hope you enjoyed the webinar and gained knowledge from the sessions. And we'll be glad if you could join us in next webinar, which will be scheduled, and the dates will be informed to you by email. We'll be very happy if you could share your opinion and feedback with us. Thank you, everyone.